So it's interesting seeing how things have evolved, starting at ASCO 2014 when Sweeney presented Chartered. Well, the press release had actually come out 6 months before that from the NCI. So the press release came out like end of 2013, right at the beginning
December
of 2014. And so at our tumor boards, early on, our medical oncology guys were very skeptical about chemotherapy with the low volume disease based on Chartered and the French study. But, and I guess then what happened right after ASCO 2015, or when the Stampede data was leaked and then presented, that seems to all have evaporated. So it seems like at our tumor boards now, if I present a case as a urologist, all the medical oncologists are cool with docetaxel irrespective of high or low volume. I don't know if that's just at our institution, or is that what you guys are seeing?
That's happening, yeah.
Mike, is that what you're saying?
Yes.
Both high volume and low volume?
Yes.
Interesting.
I think that, the power of Charted was very simple. This trial was designed to detect the difference between adding chemo or not, period. So the concern that I always have when we actually are making clinical decisions on a daily basis is that we use subset analysis to make those sort of judgment decisions on a clinical basis, right? But the reality of it is the subset analysis between low volume and high volume, the study was not powered to detect that difference. Now, what is more important to me is when we talk about median survival, right? And median survival for some patients and physicians alike doesn't resonate a lot, but just take into consideration hazard ratio, right? And look at the evolution of hazard ratio over the last 10 years in prostate cancer. In fact, since 1999, when mitoxantrone became FDA approved, just with no survival benefit, but just quality of life and pain improvement, right? Hazard ratio back in the days was around 0.8 or greater. And since then, when you think TAX-327, when you think about SWOG 9916, hazard ratios in the 0.76 range. Now, guess what? The hazard ratio of any therapy that we have right now is in the 0.6 range, right? Where you use, Uncharted for that matter, the hazard ratio of those patients who got ATT and chemo is 0.61. This hazard ratios to me really mean a lot because that clearly states that we have drastically changed the outcome of these patients. I think that Stampede, to me, should settle that issue, about low volume and high volume. The subset analysis of low volume and high volume using the Charted definition has not been presented yet, right? So I would argue, and I wonder what you guys think about this, if Stampede, comes out and says low volume patients using the definition that Charted use don't have a median survival improvement, then the question is, should we pause and stop using chemotherapy for those patients with low volume disease until we get a little bit longer follow-up? Or should we still say, you know what, every patient should get chemotherapy? And that also is, how do you define volume?
Yeah,
right?
Well, we asked that at the very beginning of this.
The hazard ratio in the low volume cohort is still
0.6,
low.
yeah.
It's just that the medians haven't been reached.
Yeah.
And keep in mind that the study started out as a study for high volume disease. So the low volume patients have two things going for them. They have low volume disease, and those were entered into the study late in the life cycle of the study.
Yeah.
See, I would also ask the question now again, and you guys have done some work in this, in these patients with low volume disease, or let's use a different terminology, oligometastatic disease. What is the role of the management of the primary in those patients? Because now we have some very sophisticated rapid autopsy next generation sequencing studies looking at the METs, that all the METs come from a clone that has actually come from the primary, and you have this reseeding and seeding phenomena.
Well, speaking of oligometastatic disease, my former fellow Axel Heidenreich, who is now chair of urology in Cologne, had one of the hot papers with the surgery for oligometastatic disease, and that's setting the urologic surgery community on its head. So now there's a series of trials starting to address radical prostatectomy in oligometastatic disease, where that's going to fit with Chartered and Stampede. Just as a follow-up question for the urologist. So, let's say I have a new M1 hormone-sensitive disease. I see the data. I know the right thing to do is to get that patient in for medical oncology for docetaxel, and I want to set the stage of optimism. But is there a group of patients where I don't want the patient to be disappointed? Like, I'm going to really play up docetaxel, and then the patient's going to go to medical oncology, and they say, oh, you're really not a good candidate. Is there a subgroup where you would pause and say, sir, this may not be for you?
Well, I think obviously if you had neuroendocrine, right, you wouldn't use docetaxel. You would probably go more towards platinum, right?
Yeah.
Yep.
Right. Well, so patients who aren't candidates for upfront docetaxel
Yeah.
is the question. The challenges I've had challenges have many of my colleagues with older patients,
Yeah.
where the goals of therapy may be a little bit different. But it's still worth having the conversation. I've given docetaxel to men in their 90s, so there's not an absolute cutoff of when it is in or not appropriate, but it has to do with frailty and comorbidities and all those other things. And so I would say I would urge a little bit of caution in recommending and being terrifically optimistic about the benefits of docetaxel in a patient who is, aside from his prostate cancer, frail or sick.
Is there a frailty? Is there any kind of simple frailty score or
Absolutely.
thing that what should the urologist use? What tool is there? A tool that's the best?
There are frailty indices. There's a whole field of geriatrics that
Right.
studies this, of course, comorbidity indices and things like that. And there have been some retrospective analyses looking at this. It's like nomograms. You can come up with scores of this. They are a bit intuitive, and I ask questions about, what's your typical day like? How if I wanted to go for a walk with you, how far could we go? And these types of things. And I guess over time, talking to many patients, you get a sense as to where that's gonna pan out.